what? Mm-hmm. Like, no, it's not a 16-year-old having a stroke.
It was not a dry eye in the room. Even now, it's like I can feel the emotion of it.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
It's been a while since we've been here.
I know, we kind of got a new little setup, too.
Uh-huh. It's nice.
A new little table, some mics. I feel like, well, I feel like Joe Rogan, but you're more like Joe Rogan.
No. The table is great. I love the table. Did you turn on the LED lights? I mean, I know if you're listening.
Yeah, it's a listening thing.
No worries.
I shouldn't have.
But the thing that gets me the most excited are these
these
and we get crazy. No royalties or anything for telling you about these Ultimas, but this is what Joe Rogan uses.
Oh, okay.
And the mics are the same too.
Oh,
they sound so much better.
Oh yeah, they do sound better.
If I can keep my mouth on the mic.
So hopefully we sound better, and you're not looking at us because we don't look any better.
No, that's right. It's a face for radio.
That's right. So we just filmed a lecture on strokes, CVAs.
That's right.
And so we were going to do a little podcast on strokes. And
this was inspired when we were at IndyCar, and we were talking to the pit crews out there and seeing those cars so fast.
Yeah.
And when seconds matter.
Yeah.
When you're racing, that mentality. I know Seattle with CPR has kind of gone through that sort of mentality, and I think with strokes we have to have the same one.
Yeah. Time is tissue.
Yeah.
Gotta recognize it fast and get it. That's really the key to stroke management pre-hospitally is recognizing it fast and take them to the appropriate facility.
Correct.
So there's nothing really else that we can do. Maybe bring down the blood pressure if it's super high, but other than that,
a couple important pieces of historical information and potential airway problems. I guess we could talk about that later too, but yeah, it's really about recognition and getting them to the right place.
Super good assessments.
Yes.
Yeah. So I think that's a good place to start because that's where we start with our patients, right? We get the story and then we do an assessment.
Correct. So we get the story of usually some sort of weakness or
altered mental status.
Altered mental status is probably the most common one.
Yep.
Yeah. And then the found down, and you get there and on your assessment, you figure out, wow, they're paralyzed inside of their body, or that looks like a facial droop, or
right.
Yeah.
After you've been doing this a while, I mean, you can really spot, and I'm sure you feel the same way as a physician. You can spot a stroke pretty quick. Yeah. I mean, you can at least see this patient appears to be having a stroke pretty quickly once you've seen it once or twice. Correct.
And a stroke isn't going to come on subtly. It's going to be all of a sudden, whammo at it. I mean, if you're able to, if you sleep, you may not know that last normal, but typically strokes come on quickly. Anything vascular comes on quickly, just by nature of it being vascular. So you get that clot or plaque that starts to block some of those arteries in your brain, and that area of the brain's not getting the blood that it needs. Whatever that area of the brain did, it can't do it anymore, and that's really what a stroke is. And
just like a heart attack.
That's right. And so we can assess it, like you said, assess it on our exam. The first thing we get, of course, is the history. We get called out for an altered mental status patient, right? So right then we know, okay, altered mental status. Sometimes I feel like the medics that I talk to, especially the newer ones, altered mental status itself is turned into this diagnosis where people forget sometimes what those words mean.
Yeah.
The brain's not working right now.
There's got to be another cause.
There's a cause. There's something going on. And it may just be as simple as blood or an intoxication or blood sugar or blood pressure. But when you do an assessment and you see that, wait a minute, this is a different kind of altered mental status. Exactly. Then that's a 5-alarm fire. Strokes.
Yeah, I think it's good too. Even if you're just a 2-person ambulance, it's good to kind of divide and conquer. One person go to the patient, do a stroke assessment. Other person get with the family member or the bystander and get some history. When did you last see them? And as doing CQI on calls. the biggest thing I see is the accurate last known well time is so important.
Really important.
So important for us to get, because giving that information to you at the hospital dictates what you can do and what you can't
Exactly. And if I don't get that information, it's going to create a delay.
Yes.
Whether it's me calling someone or talking to the family again.
Yes.
And again, like we're talking about, these seconds really count.
What is it, 1.9 million neuromyelated, what is it?
Yeah, yes, you're right. 1.9 million neurons you lose every minute. It's equal to what's, I think, 7.5 miles of
that's what
myelinated fiber. So we've said it.
I combined the two.
It's a lot. And you lose it quickly.
Time is tissue. That's the fireman way to say it. Yeah. So, timing is very important. And getting that last known well, we were talking before we started. In my experience, a lot of times when I would get these calls, it'd be first thing in the morning.
Right.
Patient went to bed, nursing home or at home, woke up, caregiver woke up, family member woke up, spouse woke up and found them in bed not acting right. And then that's when we get the call, 6, 7, 8 o'clock in the morning. And then trying to get, the last time I saw him was,
last night.
Yeah. And so we don't have that accurate time. And that's really hard.
Yep. The wake-up stroke.
Yeah.
No, that's right. I think that's one of those classic presentations. I think the common, that is a very common situation, and the common, I guess, constellation of symptoms, I think, if there was a most common, the facial droop and the unilateral weakness would probably be the most common presentation. Yeah. You might want, it can interfere with your speech.
Yep.
Actually, it can make you can get slurred speech with a facial droop, because it's just your mouth's not working quite right.
Yeah.
Or you could have the brain centers for speech can get affected commonly, and now you just cannot talk, or you've got word salad, depending upon what area of the speech centers you hit.
Yeah.
They're called a Broca's aphasia or Wernicke's aphasia.
Right.
It's not important here, but those presentations are pretty common. It'd be interesting, I think, to talk about two different types of presentations.
Okay.
I'm just thinking off the cuff here. Is the LVO presentation that's typical. And I like what you said earlier. I think we should say that again. And then the other one are the subtle strokes that we can miss. I think those would be a good assessment to talk about.
So you go, you're doing your stroke assessment. Follow your protocols. Everybody kind of uses different assessments. Cincinnati stroke scale, I think, is probably one of the most popular. The Lamb scale is probably right up there. So facial droop, it always cracks me up. Everybody always does grip strength with the Cincinnati stroke scale, and it's not actually part of the Cincinnati stroke scale. It's with the Lambs. Yeah. So Cincinnati is facial droop, arm drift, and slurred speech. And so those are the three things we're looking for, right? If I see one of those things or any of those things, right, there's a high probability
that it could be.
That it could be a stroke, right? We don't definitively diagnose anything in the field, but I'm definitely taking that patient, depending on the time frame, to a facility that can handle a stroke.
And the value of the Cincinnati scale, I mean, to your point, if you have one of them, you have a percentage chance that you could have a stroke.
Right.
But the real high percentage is that if you don't have any of them, it's unlikely to be a stroke.
Right.
Which is the real cool thing about that screening tool.
Yeah.
The Lambs is a bit different.
It gives you a score.
It gives you a score, and if you're over a 4, I think it is, then you're at the increased likelihood of it being a big bad one, an LVO, a large vessel occlusion. Those are the STEMIs of the stroke world. Those are the big ones. Those are the ones that can be retrievable.
Yeah.
And that's really important. The neurologists and neurosurgeons will call the area of brain not getting blood a penumbra. And if you block, like we were talking about on our lecture, I know you may be listening and not seeing this, but if you can imagine your wrist, and then your wrist divides into 4 fingers and a thumb, or 5 branches, fingers. Right?
5 fingers.
You've called it. I say 4 fingers and a thumb.
Well, they're all phalanges.
They're all phalanges. But
is your thumb not a finger?
No, I think it's what separates us from the primates.
Well, I get that, but it's still a finger.
To me, it's I don't.
A thumb.
It's a thumb.
Okay, got it.
They're all digits.
Philosophical differences.
Well, to me, and maybe I'm wrong. this is just me, but to call my thumb a finger, it just doesn't sound.
Are
right
you saying
to me.
like medically, a thumb is not called a finger?
Well, to me, it's a digit. It's a phalange, or whatever, and all those things. But to me,
Oh, it's definitely a unique finger.
Yeah, I see what you're saying. Like you would say, like index finger and thumb would be the unique names of those fingers.
Correct.
Okay.
That's how. They're all fingers, but they have.
Yeah, to me,
we're all people. You're
that's
Erik.
funny. I never really thought about that. That's weird.
I never thought about that either. It's interesting.
So your wrist divides up into 5 digits.
Yeah, there you go.
5 branches. Yes. And so you can imagine if you blocked a branch where your thumb is, you're only going to be blocking the brain that thumb fed, right? That blood vessel fed. Yeah. Now, if you block at the wrist, all 5 branches of that artery or that vascular system are going to get blocked. Now you're going to have a lot more acreage not getting blood, and you're going to have a lot more symptoms. So to your point earlier, I think what you said it's really cool. I've not heard it said that way, but I think it's perfect, is that if you have a lot of different symptoms, you're at increased risk for an LVO.
I mean, when you think about the pathophysiology of it, it makes sense, right?
Yeah.
There's a large area. There's several things that are being affected, so it must be a large blockage.
That's
or
right.
a blockage of a large vessel.
Yeah.
Yeah, that wasn't my creation. I was a former medical director kind of said, this is kind of the common sense way of looking at strokes.
I like that.
And if I see somebody with facial droop and unilateral weakness, I'm thinking big LVO, and then you combine that fixed gaze. Anytime I look at the fixed gaze, I'm thinking, they're having a big old stroke.
Yes. And I call it a hemi-neglect, but it's the same thing as calling it a fixed gaze or even a gaze preference, is when you're staring off to one side. Right. And basically the other half of your world doesn't even exist. Right. So if you do deprive one of the hemispheres of your brain, your cortex, from blood, you'll oftentimes get that hemi-neglect or the gaze preference or fixed gaze. And that's what will happen with that huge acreage of obstruction. Yeah. Like when you hit that proximal artery, that bigger artery.
Yeah.
They map out some of these cerebral arteries, like into segments.
Yeah, right.
And the closer you get to its origination, the numbers are like an M1 or anyway.
Right.
Not important here, but you block it proximally, you're going to have a lot more acreage affected. And if you block a big portion of your hemisphere, your cerebral hemisphere, you're going to have that hemi-neglect.
Right.
So if you see somebody staring off at the wall, you want to be careful. You're probably dealing with an LVO.
And they look in the direction on the side that the damage is, and then it's affecting the opposite side. So if they're looking to the right, it's probably the right side of the brain that has the blockage, and their left side physically is what is.
Yes, I think that's
symptoms.
right. Yes,
we looked
I think
that up.
we did.
Pretty sure that's what it was.
That's one of those things in medicine. I always flip them around.
I know,
in my
I
head
do too.
because
So if we're
seizures
incorrect, you can yell at us on YouTube.
Seizures are the opposite.
Yes.
Seizures, you look at the lesion. I think it is. Yeah, is that right?
No, maybe it's opposite in stroke.
See what I'm talking about?
We should look it up.
But you know what's cool, and one thing that you and I love about this thing is that this is one of those things that clinically doesn't matter.
It doesn't matter. Yeah.
And
it's just kind of an interesting little thing of knowing, like, it's here. It's kind of like knowing. I mean, it's like a STEMI, like which coronary artery is occluded.
Yeah.
Okay, doesn't really make any difference to me. I mean, as far as like back in the day, you wouldn't give nitro, but they're having a heart attack. I need to get them to a cath lab.
Correct.
Let's not overcomplicate this.
Yeah, I like that. It's like I think I've heard people say, let's not major in the minors. Let's stick
people
with
have a tendency to make things very complicated.
Yeah,
and it's a lot of common sense.
And there are some details that are important clinically, but to us in our 7-minute transport times, they've become, now if you're a rural agency, some of these things can become bigger deals, but no, you're right. I like that. It's we give each other a bit of a break on those things.
Yeah.
Didn't you corrected me on something the other day too? I had something flipped around with the oxygen dissociation.
Oh yeah, you were saying the right shift on the pediatric fevers. The right shift was not consuming more, holding on to oxygen when it's releasing. Yeah.
Anyways, but
that's why we work together.
That's right. But with stroke though,
yes.
If you see somebody staring off to the side, and that could be a bad sign of a potential LVO, along with the facial droop and the unilateral weakness. And we're not talking about a drift; we're talking about flaccid paralysis, just drops to the bed.
Yeah, or no movement whatsoever.
No
Can you
movement.
squeeze my hand? There's nothing, and that patient that can't talk.
Yeah.
And one of the things we said in the lecture, I always say this when I'm teaching strokes, is just because they can't talk to you or they can't move one side of their body doesn't mean that they are not conscious about what is happening. Doesn't mean that they can't feel what you're doing to them. So be mindful that they can still hear and understand what you're saying, and don't say things like, oh man, this lady's having a huge stroke, I don't know if she's going to make it. Because now imagine hearing somebody talking about you like
scary
that.
enough to be locked in.
Exactly. And now you can, I think there was an episode, I want to say it was like maybe ER or some old medical show where they actually, one of the episodes, they did it from a patient perspective of inside her head everything that was going on and what people were saying, and she's talking to herself and can hear herself talk, but she can't talk to the staff, and it just gives you a really good perspective of they can still hear and understand you. So I will always talk to my patients still, even though they cannot talk to me. I will talk to them, say, hey, my name's Matt, this is what we're doing, it looks like you might be having a stroke, we're going to take you to the right facility, we're going to take care of you. Keep them calm, right? That's what I would want somebody to do for me if I was in that terrifying situation.
Absolutely, me too.
So strokes. We talked about Cincinnati, talked about Lambs.
Yep. I think it's also worth, this may be a good way to conclude, but we can talk about it now too, is the FAST acronym.
Yes, yeah.
It's just, I think it's not necessarily an assessment, really. It's more of a checklist of what you better have done and do it quickly.
Yes. It's all the same kind of elements.
Yeah.
Face, smile, or
the facial droop, and then arm drift, and then what was the let's spell that word out, FAS. Slurred speech.
That's what it was. That's why I was thinking smile. Having a brain fart.
Slurred speech.
But I like the T, the time, right? Because a lot of people they might do a good stroke assessment, but they forget to get the last known well. That critical piece of information that is so important.
Yeah. I like that time too, not only because of the last known normal, but it's a good reminder. The time really matters with these. That's good. Yeah. It's fast.
Yeah, fast, and doing it fast. Doing it quickly, doing it efficiently, recognizing, this person looks like they're having a stroke. Hey, let me do a quick stroke screen. Hey, go talk to the family, find out when their last known normal, last known well was. Not the last time you saw them, not the last time you talked to them. When was the last time you saw them walking, talking, or whatever that patient's normal is? It's very important. It sounds silly to say that, but family members don't understand the importance of that question. And so it's very important clinically that you're very clear on what you're asking them. When was the last time you saw the patient acting their normal?
That's right.
Maybe they don't talk.
Oh, yeah. I saw him this morning at 8 a.m.
Yes.
Was he normal at that time?
Yes.
No, but that's when he told me he was having symptoms.
Okay.
No, that's not what I'm asking. I feel like sometimes I have to repeat this 3 or 4 times to kind of get to the, I guess last night at 8 p.m.
Exactly.
We were watching a show together.
That's when he was last seen acting normally. It's a very, very important question. And then mark that time. Write it down, whatever, that's, again, for you in the hospital is very important information. Really important.
So here's the stuff that keeps me up at night is missing a stroke. And that's something that can happen if you're too quick. You're talking to your patient. They've got some stroke symptoms, and maybe you see a facial droop and some weakness, and then you're standing at the right side of the bed and they're staring at you, right? And you don't realize that if you move to the other side of the bed, they'd keep staring off to the wrong side. So
I'll always ask them if they can track me. Like, I'll go to the side that they're looking to and say, hey, can you, and I'll go to the side where they're not looking. Hey, can you look over here? And that's when I know, like, they're not even turning their head. They're just hard looking that way.
That's
and
right.
I'm like, okay, there's
big
something.
Bad stroke.
Yeah, something big's going on here.
The other thing I think that can be tricky is dizziness, balance problems, and I guess altered mental status just in general. It sometimes can be tricky. We kind of anchor on what we think it is based on some information we got. But the dizziness and the visual problems, the balance issues, they can be strokes too, and we have to be careful for for those and not miss those.
Stroke mimic too, Bell's palsy.
That's right.
You get a patient that walks up and has this facial droop. What's going on here? As the paramedic, I'm still taking that patient to
absolutely
100%. I'm not gonna just be like, oh, that's just Bell's palsy, you'll be fine. No, they need to go and get cleared for the bigger problem. Make sure it's not that, and then if that's the lesser diagnosis.
That's right. What's counterintuitive about the Bell's palsy, it hits the whole side of the face.
Yeah.
Where the stroke doesn't hit the forehead, so the stroke is less of a facial droop.
Yes.
The full facial droop is less likely to be a stroke.
Right.
But it's good to remember that. But it's not going to change our management at all.
Still taking them to a stroke center.
That's right.
Yep. I would assume anybody that comes in with any kind of facial droop in the ER is getting a CT scan.
Yeah, I think. Oh boy, that's a good question, Matt.
Yeah.
Because that's a good question.
Yeah.
Because sometimes the classic thing, you get this 25-year-old that has a recent viral infection or an ear infection or something, and then they've had this progressive tingling in the face, and now their face is drooping. It's like, this is a Bell's palsy, and I'm sending you to the CT scanner is just going to put you.
Test, I really want to do that? But
there'll be a conversation, right?
Yeah.
Because even they are 25, things can happen, So there's, I think, there's a lot of power in communication and having a talk with this because I'm actually thinking about a patient I had, same situation. I'm sitting with the wife, the husband, we're talking, I'm giving them all the information. It's like, this isn't a stroke, right? I don't think this is a stroke, very unlikely.
Yeah.
But they did not get a CT.
Yeah.
They did not do.
And it turned out okay.
Yeah, it's a Bell's palsy.
Okay.
But in the pre-hospital environment, we cannot do a lot of these things,
exactly.
And we, things. Sometimes things take a while to manifest, and you never know. And it's not our job in the pre-hospital environment to diagnose. We're trying to identify the emergencies and get them to the place where they can be taken care of. So we don't need to be the diagnostician.
No.
Let's just get them to where they need to go.
We got called to an urgent care one time for a hemorrhage, or hemorrhagic stroke, excuse me.
Yes.
And or it said stroke, and in the notes it said 16-year-old male having a stroke.
16?
16, and I thought, what? Like, no, it's not a 16-year-old having a stroke. And so we
60 maybe?
16, 16. That's what the note said.
Oh, it said 16. I thought maybe you heard
no,
16, but it was really 60.
16 years old. Yeah, like sweet 16. And so we get over to this urgent care, and Dad, is in the ER, urgent care, with this kid. And the doctor comes out and says, I think he's having a major hemorrhagic stroke. He needs to go down to a certain children's facility. And I'm like, what? So, per our protocols, I had to call our medical direction because of the protocol, basically.
Sure.
So I called medical direction. Medical director gets on the phone, and I'm like, hey, do you really think? And he goes, oh, it's possible.
There are certain syndromes that are associated with these things called Barry aneurysms and all sorts of weird congenital things in the brain.
And that's what it turned out to be, is it was a congenital issue.
Oh, okay.
And so that was my ignorance, right? You always think, I've been doing this for 15 years. There's no such thing as a 16-year-old having a stroke.
Well, those are zebras.
Exactly.
They really are.
They are. And it was very unusual. And anyway, we took this kid, code 3, had to drive him to this facility. And sure enough, he was having a hemorrhagic stroke at 16 years old. I was thinking, holy cow.
He must have had some other syndromic signs or history. Yeah.
But it was interesting. I did, like I said, when I read the notes, I thought, this dumb urgent care doctor doesn't know what he's talking about. 16-year-old kid not having a stroke. Actually, he was pretty smart.
Well, actually, you bring up a really good point. Risk factors.
Yeah.
That is a big part of what we do in identifying the stroke. Is you see the symptoms, right? You hear the story, and then you're looking at a 16-year-old kid, and you take pause. Like, wait a minute,
this guy doesn't have hypertension. He doesn't have AFib. He doesn't smoke, probably. Right. Age isn't a factor. Yep.
Yeah, we talk in our lecture about the modifiable risk factors and the non-modifiable risk factors. Like gender, being a guy, you're at increased risk. Being old, you're at increased risk. Having a previous stroke, and I think, was it diabetes, the other one? Yeah.
Yep.
But
and then modifiable, right? Like you said, hypertension, smoking,
obesity.
Yep. I can't remember. I think there was 4, but
there was some other ones. Yeah, hypertension, diabetes. Oh no, then diabetes would have been modifiable.
AFib was a non-modifiable.
Yeah.
That was another one.
Yeah.
But without taking your
take your meds.
Take your meds. Same with diabetes. Like if you manage your diabetes, you'll be better off.
But by being risk assessing your patient, your physical exam, your history, last known normal, these are all really important in your assessment. And being aware too of the fact that when you're dealing with a stroke, you're being quick.
Yeah.
And you know where you're going to go.
Yeah.
You're thinking about all these things. You've activated the stroke already. Maybe you've sent your captain to do that in the engine, or who knows, however you're dispatched. But
probably not. The captain look at you like, what? I'm not calling the hospital.
Isn't that usually, wouldn't a stroke typically, it depends on how it's dispatched, but I know in some of my agencies the engine goes out with the med unit.
Yeah, it totally depends on where you're at. If you have that ability to have a truck or an engine go with you. Yeah, like in my current department, we don't have priority dispatching, so the fire trucks go on every call with our med units, regardless of the nature of the call. In my former department, we had priority dispatching. Yeah. So just shortness of breath call or a sick person call, it's just a med unit. But strokes, regardless, if you get a stroke call, you're getting more than likely, you're probably getting both. But for our friends that work in rural environments and like that, remember that couple, you weren't there, I met a couple from Missouri at
that conference you were at a couple weeks ago.
And they're outside of Branson, and they're a rural agency, cover a massive area, and they might not have anybody coming to help them. And so but again, management wise, there's not much we can do a stroke assessment on the patient, have one person talk to the family member or whoever's on scene. Once you identify, hey, I think this is stroke, if you have a long transport time, you have a decision to make. Okay, do I need to call for air medical, for a helicopter to come get this patient to expedite them getting to the hospital faster, or do we just need to go? Because like we said at the beginning, time is tissue.
Time is tissue.
Getting them where they need to go is super important.
One other thing I'll say before we move on to management is with assessment, oftentimes you can have what some people call mini strokes. It's really a TIA, a transient ischemic attack. So you have resolution of your symptoms in less than 24 hours. And but these, if your patient's refusing to go, which they could if you follow your protocols, but they would need to understand the fact that could be a precursor, a sign of a big bad one coming.
That's what I would always tell those patients, is that if this is the first time that's ever happened, people always talk about refusing. I've been doing this, a little while, and I have never had a patient that was having a TIA or chest pain or something where I didn't say, hey, listen, this is what I think's going on, even though your symptoms have subsided. This is a precursor to a bigger stroke. You need to go to the hospital and get evaluated. You need to figure out why you had this TIA. Where did it come from? Yes, and then get that under control before you do have the big bad stroke. I've never had a patient be like, nope, I'm good. I'm just going to stay here. That could happen. I'm not saying it doesn't, and that's when you need to document well. But if you explain well to patients your concerns, they trust what you're saying.
I'm always surprised when I take a refusal call for online medical support for my agencies, and sometimes these things people are refusing for, it's sometimes very difficult to get them to
understand.
To understand. But as long as they understand and they have mental and legal capacity, as long as you
document
the heck out of it.
Document, because that's what's going to cover you if things go wrong.
I think we've hit refusals a few times with different lectures. It's a really important skill to have because it's so common. A third of our calls, most majors, about a third of the calls. I'm not sure what it is nationally, but about a third of the calls are refusals.
And a lot of times, it's fitting, it's appropriate. You probably don't need to go to the emergency room, right? I would always give my patients options. Like, hey, look, here's the deal. You cut your finger, you need some stitches.
Right.
Okay, do you need to go by ambulance? No. This isn't a life-threatening thing. I'm happy to take you. I will take you if that's what you want to do. And then the age-old question is, well, won't I get in faster if I go by ambulance?
Maybe
not necessarily. Not if you have a cut finger. But, can you drive yourself? Can somebody drive you to the hospital? An urgent care could take care of some stitches, right? Be a whole lot less expensive for you, too, going to an urgent care. Anyway, verbal judo is important.
You got to be careful talking about money. I know that can, there have been some, you got to be careful. You got to be careful how you talk about these things. But if the patient does say, I'm concerned about the money, oftentimes I'll say, well, how much more important is your life?
Right? That's the easiest question. What price would you put on your health?
And it's different at 2 a.m. when you've not slept yet.
Yeah.
And the calls just keep coming.
Oh, yeah.
And there's a refusal.
Yep. Oh, I can go back to bed.
And that pushes hard.
Yeah.
But it's important to do the same thing every time.
Yep.
Push.
It is.
Look out for those
really
patients. Yeah. So we've gone through assessment.
Yep.
So now we've had our stroke. I think one of the well, you've already said it, but one of the most important things to know is your agency's proximity to hospitals and their capabilities. You got to know where your stroke centers are.
Yeah. And the different stroke centers.
Yeah.
I mean, I would think across the country, like primary stroke center is a place that can give TPA.
Yeah, I think any ER is going to be able to do TPA.
And then a neurointerventional, or some used to be called comprehensive, different terms, is where they have a neurologist that can actually go in and grab that clot.
Yeah, they call him a neurointerventionalist,
right.
And it's a neurosurgeon who can go in there and suck that clot out.
Yeah.
Yeah. Just like a cardiologist, there are certain cardiologists that work in the clinic, and then there's certain cardiologists that are interventionalists, and they can go in and do those angiograms and do those procedures. So yeah, you're right. We need to be in a place where the cath lab is available to do that thrombectomy potentially, especially if it's an LVO.
Yep.
That's where things get really important.
Know where those facilities are is, as from a pre-hospital provider perspective, knowing where the closest facilities are. And like I said, if you're in rural Missouri, that comprehensive neurointerventionalist might be an hour drive or longer.
Yep.
And so that's where you'd have to consider, do I need to call for a helicopter?
Yeah.
They're probably not going to clinically do anything different than you can.
You're right.
But it's about time. It's about getting them there quick.
And if you are having trouble getting an IV, try again.
Yeah.
This patient's going to need an IV, and if you can get an IV, it's going to help to expedite things when you get to the ER. Where sometimes when you're trying to get an IV on a patient, you may not want to stick them too many times because they've got their vascular access team or ultrasound or who knows what.
And we all know that paramedics are better at getting IVs than nurses anyway. So.
Better than doctors,
Gonna
for sure.
get some hate for that one. Just kidding. Just kidding. I can say that.
It's funny when like I'm on a ride out or whatever, I want the doctor to get my IV.
Oh, I know. Yeah.
No, you don't.
No, you don't. Yeah, that person hasn't been a paramedic very long if they're asking you to get the IV.
Oh, no, it's the patient.
Oh, yes,
patient.
yes.
They see MD on my...
Yes, and they're thinking, oh, I want him to...
Doctor?
Yeah.
Why is
you want him to drop the tube, maybe, but not get the IV. Yeah. How
funny.
often... Would you ever start an IV in the ER? I know you said you did it on the plane. That was the first one you ever did.
Well, okay, so truth be told, in medical school, you have to do a certain number of IVs, and you've got...
What's a certain number? I'm curious.
I can't even remember. It feels so long
Like more
ago.
than 10?
I think so, maybe.
Okay.
Like you're on a rotation, and like that's part of what you have to do and get signed off for these things as a medical student.
It's just a check off.
I think. And then and I think we had some procedure labs where we were doing IVs maybe as medical students, but man, in residency, we were training more on the central lines and those types of things. Stuff, and arterial lines and whatever. Anyway, so no, I don't know IVs. I mean, I watched my nurses do their little finger flick deal, you know, and so when I was on the plane and I had to do it, I'd never really done it. I was a little nervous, I got it first try. Got lucky. She had some pretty good veins, but she was looked like DKA. The glucometer was high. She's breathing fast. Yeah. But I got that IV, and I wanted to slap somebody high five. Yeah. But I had to pretend like I'd been there before.
Stuck on the water. Feet are just kicking under.
I'm
so nervous.
I sat down and I told my wife the story when I went to sit with her on the plane and was explaining to her how excited I was.
She's like, "Oh, my husband's just being a hero again."
You're right.
My daughter called me. She's in nursing school, and she called me. It's been a couple months ago. She was doing clinicals. She texted me and she's like, "Dad, guess what?" I said, "What?" She goes, "Got my first IV." She was all excited.
Nice.
So I remember those days. Yeah, well, as paramedics. I guess nursing school, definitely as paramedics, I started way more IVs in paramedic school and clinicals than I did in nursing school.
You did?
Way more.
Okay.
Way more. But anyway, yes, IV access is super important. They're going to have to have that. And a bigger, like if you can get an 18 gauge, is going to be a little bit better. So don't be afraid to go for that AC.
Where I've seen some of the delays are is when we get them to the CT scanner. It's the first place you're going to go with the stroke. Yeah. If they're really hypertensive, that we're trying to get the point of care labs. We're trying to get them some, medication to get the blood pressure down.
Right.
So if they are a candidate for TPA or, well, there's a tenecteplase. There's a lot of different ones, but then we need to get that blood pressure down.
Yeah.
So that having that IV up front can really save some time.
Absolutely.
So.
Yep. IV skills are important for sure.
And if that blood pressure is out of range, giving them, if it's in your protocols, be careful though, because hypotension is the enemy here.
That's right.
With these strokes,
brain, that's right.
Yeah, but
usually most protocols will have a range. I would think you don't want to get it below
if it's over a certain number
or something. Well, depending on the protocol.
Yeah,
you don't want to drop it down to 120 over 80. That's not what we're looking for.
That's right. So that could be a management in some agencies, depending upon your protocols.
Yep.
Airway, we mentioned that.
Yep. I've never had to tube a stroke patient. Have you?
I have. Yeah. This was, but when they're vomiting or they can't control their secretions. But I think this patient was actually dying because there's so much, and he was herniating. I mean, then they needed. Their GCS was so bad.
Yeah.
So sometimes we do, but you're right though. Usually we don't. Yeah. I mean, they're staring at the wall. They can't talk. Their GCS actually would be really bad, right?
Yeah,
because they're paralyzed on one side of their body.
Exactly.
They can't talk. Yeah. They're opening their eyes spontaneously, but so you might think based on GCS we want to intubate them.
No. Airways patent typically, obviously watch. Monitor their vitals, get them on end-tidal, get them, see what their SpO2 is. But, I've never even considered, thought about it, but it was a fleeting thought. Like, okay, we don't need to tube this patient.
And strokes can progress, too. They can progress. So you might want to repeat that exam again as part of your management, right?
And be watching your patient. Like, is their slurred speech getting worse? Mm-hmm. Is their weakness getting worse? Is it getting better, right? It's very important to reassess your patients regardless of what the complaint is.
To go backwards a little bit, we should know if they're on blood thinners. We should know we have their med list there. Yep. We've got their history. Have they had a stroke before? Yep. All these things are really important. Yep. But as far as airway goes, though, being really careful if you do have to take their airway or to assist them, put them in a better position, whatever you have to do. That is a potential emergency. We don't want to complicate their stay. We need to get them to the hospital and getting the oxygen, getting the, and again, we talked about this before, but if their SATs are 98%, they don't need extra oxygen.
No, you don't have to, it's not making you feel any better by putting
No. And you could be causing harm. You could be causing harm like radicals. We talked about before. Yeah. So, it's easy to want to just slap some oxygen on them, but we have to
feel like you're doing something because, like we said, there's not much to do on these stroke patients. So, I'll put them on a nasal cannula. Yep. Like you said, they're 98%. They don't need.
You're right.
They don't need it. So, assessment, management, taking them to the appropriate facility.
I forgot to say, we'll pick it up with facilities again, but I forgot to say something earlier with assessment. Actually, I think is really interesting about strokes is that when you have that hemi-neglect or the fixed gaze or the gaze preference, whatever it is that your brain it does some weird things. Yeah. And I just think it's interesting. The brain is so complicated. If you showed these patients, and if they could talk to you and answer your questions, which sometimes they wouldn't be able to, but and you showed them a picture, they would only see half the picture. Yeah. If you had them draw the numbers on a clock, they would put 1 through 12 on one side. If you had them eat off a dinner plate, they'd only eat off half the plate. If they had a hemi-neglect and they're staring off to the left, the right side of their body doesn't exist. Right. If they were able to articulate and see a ring on the right hand, they would think somebody stole their ring. Yeah. They'd identify the ring as theirs, but the hand's not theirs. Yeah. It's really interesting. The brain is such a complicated organ, and it's really understanding some of the pathophysiology of a stroke can really be very, very interesting and really help us to understand more of our protocols and why it's so important to get these people quickly to the appropriate facility, get fixed, only because it can be so catastrophic.
Tell your song story.
Oh yeah,
I love that story.
Oh, that's right.
Yeah.
That's actually what I really want to share.
Yeah. Oh,
you're so
perfect.
smart. Yeah, I'll never forget her. I know her full name. I can't share it here, obviously, but she was Tongan, and her family was with her in the hospital. I'd seen her in the emergency department. We got her admitted to the hospital, and there was just such a big family. And so after my shift, I went up and visited them and said, just
how you doing? Yeah.
wanted to just express my condolences, and because in the ER, unfortunately, we don't get to spend a lot of time with our patients.
Same with us.
And it's kind of hard sometimes because you
don't get that closure, kind of like what happened to that lady, what happened to that guy.
Yes, you see the sadness, you see the tears, and you see the pain, and then you in the ER, just like you dump them off in the ER, and then
on to the next
you
one.
go to the next one. In the ER, we do the same thing. I dumped them off into the ICU. I got the admit orders in, and I don't get to see them again. So every now and then, when these types of patients will come through that I really felt connected to, I'll go see them. And so this young lady, well, not young, this matriarch of her Tongan family, I went and visited her after my shift just to say hello, and there were more people in the room. There was a huge family. And so I thought, gosh, you know what? I remember reading that oftentimes people with a stroke on the left side of their brain can't talk.
Oh, this was in the ICU this did?
Yeah.
Oh, I thought that you actually did this in the ER.
No.
Okay,
no.
sorry.
This was in her in her room.
Okay.
Yeah. It was a full room, lots of visitors. And so I'd said to, I almost said her name, but to Susie.
We'll call her Susie.
Susie.
Yeah.
I said...
common Tongan name.
It is very... Actually, her name doesn't really sound Tongan either, but anyway, whatever. Yeah, Susie. So walked into the room, ton of people in there, and I remembered reading that oftentimes people with left-sided strokes who hit that area of the brain and the speech centers end up with an aphasia, but the right side of the brain is unaffected, and that's how we sing. And so oftentimes folks that can't talk, and they don't even know it, they can actually sing if you ask them to. Well, nobody had thought to ask her to sing. Family's devastated. They're praying, they're crying, and everybody's holding, Susie's hand, and it was sad. You could just feel it, imagining her as your family.
Yeah, sure.
And so I said to Susie, would you mind trying something with me? Now, like you said earlier, she can't talk, but she totally understands every word I'm saying. She can't nod her head yes or no either. That's an expression. You cannot even do that. It's not like you can't just talk. You can't even express a yes or no by nodding your head. You have no expressive language. But the look on her eyes, you could see she understood me, and I knew she did physiologically. You just know how strokes work, like you said. And the family answered for me when I asked what her favorite song was, and they said, "Jesus Loves Me." And so I asked her to sing, and she sang in perfect pitch, "Jesus Loves Me." It was not a dry eye in the room. Even now, it's like I can feel the emotion of it.
Oh, I'm sure.
And the family... It was such a special moment for them, and I got to witness it and be part of it. By understanding the pathophysiology of a stroke, I was able to deliver healing by my knowledge of what was going on. And now you're hearing this story. You might be in a situation someday where wait a minute, Matt and Erik were talking about these left-sided strokes where they can't talk and right-sided weakness. I asked my patient to sing, and she could sing. It's really special. But that's why I like to talk about the pathophysiology of these things, because oftentimes understanding it might be helping you to be better equipped for a proper refusal by helping your patient understand what's going on. It also might be a source of healing potentially, like I experienced with Susie. That was very special. So
I love that story. That's a cool story.
And that's management. That's a lot of management there. I think the last thing I would say, kind of reminded me of it with a big family, is managing family. That can be a big deal too. Because it can be a scary time, and getting family to calm down so you
Yep.
can do your job.
Yep.
It's tough in a house. There's people,
Yeah,
it's
everybody's
chaos.
freaking out. They're scared. Yep.
And then that can impact you. And I think one of the things I learned, to circle back to the pit crew, I asked him, the captain of that pit crew, that IndyCar pit crew, amazing. Those guys are so good at what they do. But I asked him, well, give me one piece of advice that we could use in our environment, that you use in your environment, that you think might help us. And he said, stay calm.
Yeah.
Stay calm. Don't let the environment ramp you up that you'll start missing things.
Yep.
And you won't perform as well.
That's pretty universal. I've heard military guys say the same thing.
Yeah.
You know, like anybody. Well, freaking out never solves anything, right? And, you know, it's funny, not really related to strokes, but, you know, people always ask, I'm sure they ask you the same thing, like, I couldn't do what you do.
Mm-hmm.
And I'm like, well, I think really the difference is training. Right, we're trained to know what to do in these situations, and then obviously after you've been doing it for a long time, you have experience dealing with chaos and dealing with emergencies, and you know what you need to do, and so you're so focused on what you need to do that the freaking out doesn't even enter your brain, because you're like, nope, I've got to do this, I got to do this, I got to do this. So you're so honed in on what your job is, where the layperson that doesn't have a medical background, they have no idea what to do. And so they just freak out because it's like, well, I don't know what else to do, so I'm just going to freak out. But freaking out in a stressful situation doesn't solve anything.
No.
Doesn't help anything. Calm down and think.
Yeah, being calm. And by doing that, by, you know, when you do get freaked out, you less blood's going to your prefrontal cortex, where you have the processing demand that you need to make smart decisions. You start to think with the reptilian portions of your brain, your amygdala. Yeah. That's never a good thing.
And it makes you feel a lot better and more confident and comfortable as a, you know, provider, that when you can, the more you study and the more you learn, right, the better you're going to be able to deliver care to your patients. And the more calm you're going to be, because you're like, oh yeah, I know what this is because I heard this on a podcast, or I watched this on a lecture, or I've seen this before.
I've practiced this scenario before.
Exactly. It's like doing a skill, right? Well, I've never done an IV before. You know, you're nervous, right? Doing that IV. I've never done this before, right? Everybody's thinking the big doctor is going to be able to nail this.
They were all watching me kneeling in the aisle.
Exactly. You know, where like I would go in like, well, yeah, I'll get you an IV. You know, so just because I've done them so many times. But yeah, that it's so much better to be knowledgeable and experienced out there. It'll calm you down as a provider.
It does.
And you'll be able to treat your patients better, for sure.
Well said.
What else on strokes?
Well, there's I think one of the things that sometimes we don't think about sometimes with, and it's not necessarily just with stroke management, but you know, any time you're dealing with a time-sensitive diagnosis, you've got to. I think it's important. You know, you're done managing your patient, is to circle back and debrief with your crew
After the call.
Yeah.
Oh, for sure.
And to discuss, well, what could we have done better?
100%.
Gosh, you know what? I wish I would have done this first.
Yep.
Or how did we miss the last known normal? How do we prevent that from happening again? You know, maybe we messed up a little bit, right?
Yeah.
But let's not let it happen again.
Yeah.
I think that debrief is a really important part of it, and hopefully that'll improve. You know, you can always do better.
Yeah.
I think I was actually talking to a fire chief about this last night.
Mm-hmm.
We were talking. So I think when, as a medical director, and I think too, when you're in your position of leadership as your EMS captain position, when somebody makes a mistake, we have an opportunity to help improve things, and that's
because we all make mistakes.
We all make mistakes.
We're all human. We're going to make mistakes, and you have to be open and honest and vulnerable. Our battalion chief at my current department, they were doing a PIA on a structure fire they had, and we were talking about it beforehand. He said, "Yep, time to go get naked." And that was his. It was it's time
just to be vulnerable.
Yeah, obviously not literally get naked. It was time to go in and just be like, all right, here I am. You know, what did I do wrong? And so, and that's just, you know, from a, you know, we like to joke around and first responders, firefighters, whatever. But that's a good way to look at it. Like, you have to be willing to get naked, right? Be vulnerable about what you didn't do or what you did do on that call to learn and be better next time.
I think that one thing I've learned as a medical director is that I think in our industry, I guess, if you will, we're really hard on ourselves.
Oh, yeah.
You make a mistake, you punish yourself a whole lot more than I ever could. But if I'm going to do the same thing and heap it on top, it's just going to make it worse, I believe. So as a medical director, I've become more careful with how I respond, because I know for the last week, since he made this mistake or she made this mistake, they've been beating themselves up. And the last thing they need is for me to come in and do it again.
Yeah.
So I think it becomes even more important for me as a medical director to find a support and find it as an opportunity to be able to walk through improvement, make sure it doesn't happen again.
That's all
punishing.
That's all part of the just culture thing, right?
Yeah.
You have to look at it's human behavior, it's at-risk behavior, or it's dangerous behavior, right?
Yeah.
And oh, I didn't see that stop sign. Oh my gosh.
Yeah.
Okay, you made a mistake. You didn't see the stop sign.
Yeah.
Right? Or you're knowingly driving 80 miles an hour in a 40 mile an hour zone. That's at-risk behavior.
Yeah.
And then you're driving intoxicated at 80 miles an hour blowing stop signs. That's dangerous behavior, right? That's that just culture mindset. As a leader, if I'm dealing with somebody that has made an error on a call, I love the person that comes into my office humble, that has beaten themselves up, because I'm like, that I can work with that. I can work with that because that tells me you care about your job. You made an honest mistake, like I have done 100 times, and we can learn from that, and you're going to be better because of it. It's that guy that walks in with that I don't care attitude that I made a mistake.
That's trying to hide it or lie about it.
Or trying to hide it or lie about it. And that's why we say all the time, in the fire service, like, integrity is a huge thing. That is why. That's why, because if you can't acknowledge that you made a mistake, you don't care that you made a mistake and potentially put somebody's life at risk, that's a problem.
That is a problem.
That is a big problem. We all make honest mistakes. Own it, admit to it, learn from it, move on from it. Yeah, anyway.
But
we'll
I think
talk about that more later.
No, yeah, you're right. That's a whole podcast in itself. But I think with stroke assessment, as we close up here, is where these brain cells die quickly.
Yep.
These brain cells are metabolically active, and you deprive them from oxygen for an amount of time, they don't do well. And so we've got to be quick. And if we do mess up and cause a delay, we can't let it happen again, because a delay of a minute could be the difference between the husband not knowing the wife's name,
or being able to talk, or
right. So I think that with strokes in particular, well, I mean, with CPR, with heart attacks, we could traumas even, or whatever, hemorrhage. A lot of the things we deal with in our environment, like strokes, require us to be on point and really good at what we do. Not just fast, but fast and accurate, like we've talked about.
Like the pit crew,
Like a pit crew. And so if we do find that we've made a mistake, or we can shave off some time, great learning.
Absolutely.
Moving forward, we're going to do better next time. And we're always trying to do better for our patients. That's why we do what we do.
See you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.